Welcome. My name is Lieutenant David Good, and today I'm going to be talking to you about endocrine dysfunction and the anesthetic considerations related to those dysfunctions. The objectives for this presentation are the same as the topics that are outlined in this course's syllabus. It starts with summarize the anesthetic management concerns of adrenal gland dysfunction and the significance of surgery and suppression of the pituitary adrenal axis, as well as discuss the anesthetic management concerns of the outlined endocrine disorders to include diagnosis, signs and symptoms, and treatment, as well as incorporate the knowledge of the major components of a thyroid function test in the anesthetic plan. Starting with Objective 1, I want to begin by talking about the hypothalamic pituitary adrenal axis. Corticotropin-releasing hormone, or CRH, is released from the hypothalamus and stimulates the release of adrenocorticotropic hormone, or ACTH. In turn, ACTH stimulates the release of cortisol and aldosterone at the adrenal cortex. Cortisol exerts a direct negative feedback on the hypothalamus and anterior pituitary, inhibiting further release of CRH and ACTH. This provides autoregulation. ACTH is released diurnally, stimulating peak cortisol levels in the morning shortly after awakening. Cortisol levels are increased in response to stress, including surgical stress. Cortisol provides mobilization of cellular proteins and fat stores for energy and synthesis of other compounds. Cortisol levels are increased 2 to 10-fold after the induction of anesthesia and at the start of surgery. Increased cortisol levels remain postoperatively due to tissue injury associated with the surgery. Normal levels are usually returned 24 hours post-op. Increased cortisol levels are needed during surgery to reduce inflammation and to maintain hemodynamic stability through vasoconstriction. High-dose opioids can attenuate the cortisol response to surgical stimulation. Etomidate can actually suppress cortisol synthesis. Regional anesthesia inhibits the response to surgical stimulation and inhibits the subsequent release of cortisol. Increased cortisol levels are often seen postoperatively when the regional anesthesia wears off. Suppression of the hypothalamic pituitary adrenal axes is produced by chronic steroid use and inhibits the release of cortisol during surgery. Pituitary damage or adrenal dysfunction can do the same. In this case, preoperative corticosteroids are needed to maintain the ability to vasoconstrict and bronchodilate in response to administered catecholamines. The adrenal glands are located on top of each kidney. They are made up of an adrenal cortex, which is the superficial aspect of the gland, and the medulla, which is in the center of the gland. The cortex is responsible for synthesizing and secreting glucocorticoids like the already mentioned cortisol, as well as mineralocorticoids such as aldosterone, and also secretes androgens, which we will not discuss during this presentation. The adrenal medulla synthesizes and secretes catecholamines such as norepi, epi, and dopamine. Cortisol's mechanism of action is to stimulate transcription and translation of DNA for enzyme synthesis. These enzymes are absolutely necessary for life because cortisol's effects provide glucose to be utilized in response to stress through gluconeogenesis, fatty acid mobilization, protein catabolism, and decreased unnecessary peripheral utilization. And because cortisol aids in the vascular and bronchial response to catecholamines, it's absolutely necessary to provide an adequate stress response. Cortisol also inhibits inflammation by stabilizing lysosomal membranes and decreasing leukotriene migration. It decreases capillary permeability, but decreases the number of eosinophils and leukocytes, predisposing a patient to infection. Remember that cortisol is necessary for the conversion of norepinephrine to epinephrine by PNMT in the adrenal medulla. Cortisol acts like aldosterone in that it causes some increase in sodium and water absorption and potassium secretion at the distal convoluted tubule of the nephron. Like cortisol, aldosterone secretion can be stimulated by ACTH, but more importantly, the key stimulant for its release is elevated serum potassium levels. Remember that renin is released from the juxta glomerulosa in response to decreased GFR. Renin then converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted into angiotensin 2 by ACE. Angiotensin 2 causes vasoconstriction, stimulates thirst, and stimulates the release of aldosterone. Aldosterone acts at the distal convoluted tubule to absorb sodium and water in exchange for potassium and hydrogen ion secretion, with the result being increased blood pressure, decreased potassium, and increased pH. Remember the vicious cycle of CHF. CHF decreases cardiac output, decreasing GFR and stimulating RAS. Aldosterone then increases sodium and water absorption, worsening the CHF. This effect can be mitigated by ACE inhibitors or ARBs. The anesthetist must be aware of the normal function of the adrenal gland, including blood pressure regulation, blood glucose level, sodium and potassium regulation, anti-inflammatory processes, and fluid balance. But there are also dysfunctions that can occur. These dysfunctions can be associated with both hyper or hypoactivity. This brings us to our second objective, but first a quick note about pheochromocytoma. Pheochromocytoma is caused by a tumor that leads to the inappropriate release of catecholamines, causing an increase in heart rate, blood pressure, metabolism, temperature, etc. Sometimes the tumor impedes the transport of cortisol from the cortex to the medulla. This inhibits the production of epinephrine and leads to the inadvertent release of epinephrine's precursor, norepi. Norepi has a greater affinity for alpha-1 receptors than does epi, and can cause extreme hypertension. Treatment for pheochromocytoma is phentolamine for an acute exacerbation or phenoxybenzamine for chronic control. Pheo patients should always be started on phenoxybenzamine several weeks prior to surgery. Cushing syndrome can either be ACTH dependent or ACTH independent. ACTH dependent Cushing syndrome is an overexcretion of ACTH from the anterior pituitary, stimulating excessive secretion of cortisol. ACTH independent is an overexcretion of cortisol from the adrenal cortex that is not related to ACTH levels. Cushing's disease is essentially ACTH-dependent Cushing syndrome. The diagnosis involves increased cortisol levels that are measured by a 24-hour urine specimen. Signs and symptoms include weight gain, moon phases, telangiectasias, hypertension, glucose intolerance, oligomenorrhea, decreased male libido, ecchymosis, and muscle wasting. Treatment involves removal of the pituitary adenoma or radiation of the adenoma. If the disease is ACTH independent, it involves removal of the adrenal tumor. Anesthetic concerns include evaluating blood pressure, electrolytes, and blood glucose level perioperatively. Osteoporosis may be a concern for positioning in these patients. Etomidate can be useful in suppressing cortisol release. Mechanical ventilation should be used because of the muscle wasting associated with Cushing's. Consider cortisol drips after removal of a tumor and expect transient diabetes insipidus following the microadenomectomy. Conn syndrome is excessive secretion of aldosterone from a functional tumor of the adrenal gland. Its diagnosis is made by noting spontaneous hypokalemia in patients with hypertension. Signs and symptoms include hypertension, headache, sodium retention, increased extracellular volume, hypokalemia, polyuria, muscle cramps, weakness, alkalosis, and hypomagnesemia. Its treatment includes potassium supplementation and the administration of aldosterone antagonists such as spironolactone and excision of the tumor. Anesthetic concerns involve correcting hypokalemia and hypertension and being aware of a changed response to non-depolarizing neuromuscular blockers. It may also require cortisol infusions after removal of the tumor. Hypoaldosteronism is a decreased secretion of aldosterone from the adrenal cortex. Primary aldosterone deficiency is caused by a congenital issue or aldosterone synthase deficiency. Hyporeninemic hyperaldosteronism usually occurs in people of age greater than 45 with chronic renal disease or diabetes. Diagnosis is typically made by noting hyperkalemia without renal insufficiency, suggesting a primary deficiency. Signs and symptoms include hyperkalemia, hyponatremia, and hypotension. Treatment includes sodium supplementation and daily fludrocortisone. Diabetes insipidus is a lack of antidiuretic hormone, or ADH, or it's a decreased response to the hormone at the nephron, resulting in decreased water absorption by the kidney. The diagnosis can either be neurogenic diabetes insipidus or nephrogenic diabetes insipidus. Neurogenic is diagnosed when administered desmopressin results in increased water absorption at the nephron. This is noted by an increase in osmolarity and sodium concentration in the urine. Nephrogenic diabetes insipidus is diagnosed when administered desmopressin has no effect on water absorption in the nephron. Signs and symptoms include hypernatremia, hypovolemia, hypotension, tachycardia, and polyuria. Treatment involves the administration of IV fluids and electrolytes, administering chloropropamide to potentiate the effects of antidiuretic hormone, and to administer vasopressin. The syndrome of inappropriate antidiuretic hormone, or SIADH, is an excessive excretion of antidiuretic hormone causing increased water absorption in the kidneys. Its diagnosis is made by noting decreased serum osmolarity and hyponatremia, with corresponding increases in urine osmolarity and urine sodium. Signs and symptoms include lethargy, confusion, unconsciousness, cerebral edema, which is noted with a serum sodium level less than 110 milliequivalents per liter, as well as arrhythmias. Treatment involves restricting oral fluid intake and administering dimeclocycline to antagonize ADH, as well as sodium chloride infusions. Hyperparathyroid is increased release of parathormone from the parathyroid gland, causing increased osteoclastic activity and subsequent hypercalcemia. Its diagnosis is made by noting hypercalcemia with increased parathormone levels, and often you note kidney stones. Signs and symptoms include muscle weakness, polyuria, kidney stones, anemia, prolonged PR interval, short QT, vomiting, abdominal pain, skeletal demineralization, and calcifications. Treatment includes sodium chloride infusions and loop diuretics, as well as the administration of bisphosphonates and mithromycin to inhibit osteoclastic activity. Hypoparathyroid is decreased release of parathormone from the parathyroid gland, leading to increased osteoblastic activity and subsequent hypocalcemia. Its diagnosis includes noting calcium less than 4.5 milliequivalents per deciliter and an ionized calcium less than 2. Signs and symptoms of acute hypoparathyroid includes paresthesias, restlessness, muscle irritability with a positive Chvestek sign, that's the facial tap with a twitch associated with it, or the Trousseau sign, which is a foot spasm when applying a tourniquet to the upper leg. Chronic signs and symptoms include fatigue, cramps, prolonged QT, cataracts, and a thick skull. Treatment includes calcium infusions or oral supplements for the asymptomatic patient. Like diabetes insipidus and SIADH, acromegaly is essentially a pituitary dysfunction. It's the result of excessive secretion of growth hormone from the anterior pituitary, which causes excessive systemic growth of tissue. Its diagnosis involves noting excess growth hormone and physical signs of overgrowth. Signs and symptoms include paracellular, enlarged cella turcica, headaches, visual defects, excessive growth, glucose tolerance, osteoarthritis, soft tissue overgrowth, and carpal tunnel. Treatment involves transsphenoidal surgical excision of the adenoma, as well as administration of bromocriptine. Thyroid regulation involves a negative feedback loop. It starts at the hypothalamus, where you get the release of thyroid-releasing hormone. The thyroid-releasing hormone enters into the portal circulation, traveling to the anterior pituitary. In the anterior pituitary, you get release of TSH, or thyroid-stimulating hormone. TSH travels through the systemic circulation until it reaches the thyroid gland. There, it stimulates the uptake of iodine, which allows the secretion of T3 and T4 thyroid hormones to exert its effects on metabolism. As T3, T4 levels increase in the systemic circulation, this causes a negative feedback at the hypothalamus to decrease the release of TRH, as well as at the anterior pituitary to decrease the release of TSH. To determine where a thyroid dysfunction is originating at, you must draw TRH, TSH, and T3 and T4 levels. An elevated T3 and T4 levels associated with an elevated TSH confirms that the problem is at the anterior pituitary, usually a tumor, which is causing increased THS secretion and subsequent increases in T3 and T4. If you have elevated T3 and T4, but a decreased TSH, the assumption is your elevated T3 and T4 is causing a negative feedback at the anterior pituitary, decreasing TSH secretion. But the tumor or dysfunction in the thyroid is causing an increase in T3 and T4 regardless of the negative feedback. The same is true for hypofunction. If you have decreased T3 and T4, along with a decreased TSH, the assumption is the problem is at the anterior pituitary, where you're not getting a release of thyroid-stimulating hormone, therefore no increases in T3 and T4. If you have decreased T3 and T4, yet an elevated TSH, the problem is most likely at the thyroid, where it's not responding to the TSH. As just mentioned, hyperthyroid is the excessive release of T3 and T4 from the thyroid gland, causing increased basal metabolic rate. Its diagnosis is usually confirmed by noting increased T3 and T4 with a decreased TSH, or an elevated radioactive iodine uptake. Signs and symptoms include hypermetabolism, anxiety, warm, moist skin, flushed skin, fine hair, fragile nails, heat intolerance, weight loss, tachycardia, and increased cardiac output. Treatment involves antithyroid drugs such as propylthiouracil, beta blockers, radiation, and surgery. To accomplish Objective 3, we're going to talk about the anesthetic plan and how it relates to hyperthyroid as well as hypothyroid, starting with hyperthyroid and pre-op. All elective surgery should be postponed until the patient is euthyroid with normal T3/4 levels and no tachycardia. If the procedure is an emergency, beta blockers, such as inesmolol infusion, and polythiouracil should be given. Intraoperatively, close monitoring of cardiac function and body temperature is essential. The patient is predisposed to corneal abrasions due to exophthalmos. You're going to want to avoid ketamine and/or muscarinic antagonists so that you can avoid abrupt increases in heart rate. Hyperthyroid does not increase the MAC. Postoperatively, thyroid storm is the most serious concern and usually occurs 6 to 24 hours post-op. But it can also occur during surgery and can mimic malignant hyperthermia. MH can be ruled out by the absence of muscle rigidity, or an absence of increased CK, or no increase in lactic acid. Thyroid storm can be treated with cooling, beta blockers, and propylthiouracil. Assess for damage to recurrent laryngeal nerve after removal of the thyroid gland. You can assess this by noting hoarseness. Assess for hematoma that may compress the airway and be prepared to open the sutures if needed. Assess for hypocalcemia because removing the thyroid gland can often lead to an inadvertent removal of parathyroid gland. Hypothyroid is a decrease in excretion of T3 and T4 from the thyroid gland, causing decreased rate of metabolism. Its diagnosis is made by noting reduced T3-T4 with increased TSH. Signs and symptoms include hypometabolism, fatigue, dry skin, dry hair, cold intolerance, weight gain, and reduced cardiac contractility. Treatment includes hormone replacement with levothyroxine. Preoperatively, patients with hyperthyroid that have decreased T3 and T4 levels should have the procedure postponed. If the procedure is emergent, levothyroxine should be given pre-op. Hypothyroid patients require minimal pre-op sedation due to increased sensitivity. Intraoperatively, patients are more sensitive to hypotensive effects of anesthetics. Ketamine or etomidate are beneficial induction agents. Postoperatively, expect delayed emergence, and make sure you use opiates sparingly due to increased sensitivity to respiratory depression. This concludes my presentation, and I wish you all the best of luck in your clinicals as well as the upcoming exams. Thank you.